Alrighty, good afternoon, everybody. Welcome to SEVA VentRounds. Today we're gonna be talking about finishing the breath, cycle synchrony, and we have some fresh cases that came out of our medical ICU today. So today is March 21st, 2023. The disclosures is we discuss particulars of ventilator modes. No endorsement of any particular mode, manufacturer, or company. We're equal users of any ventilator you put in front of us. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic's. For today, it's going to be me hosting Eduardo Mireles. Rob is not going to be with us today, but you can see my disclosures. In terms of the ground rules, just remember this is a recorded session, so keep your microphone muted. If you want to comment, just please put it on the chat and I'll call upon you. You're welcome to ask and interact as much as you want. This is how we learn. Every single one of these SEVA VentRounds, we learn something. At the end of this, actually, the Cleveland Clinic employees get CME, but also if you're a respiratory therapist, you will get a CRCE. So just put your name on the chat, which kind of confirms that you exist. And then at the end, you're going to see the QR code. And just please put the QR code, and that will help you just get the CRCE. All right. Thank you, Sherry. I see your name now. In terms of the key knowledge that we need to talk when we're talking about finishing the breath, a SEVA key knowledge fact is when does this breath end? And what we have put in this graph for you all is in this red dotted line, you see how PMOS would look. Essentially, how, if this was the esophageal pressure, how would it look as it becomes negative? The pressure in the airway would drop, and then the ventilator would trigger the breath. And in this case, it's a very small trigger, but it's enough to trigger the breath, and then the patient becomes passive. Essentially, the breath ends, and then there's this exponential nice decay. That means that there's no PMOS, and the breath ends. That would be normal in a sense. Now, we're going to argue a little bit about that in a second. The second that we call late cycle. Late cycle means that if you see here the respiratory effort ends around here, and I put this, let me use the marker here. I put this dotted line for you to be able to see it, but it's about there that the muscle starts relaxing, and you see actually on the other dotted line, where actually the breath ended. So the machine breath ended late in relation to the patient. And just remember, always when talking about synchrony, the patient signal is what is the reference. So because the patient ended here, the machine ended later, this is called a late cycle. And the key findings for this is that you're going to find during the inspiratory phase either a pause where there's no flow, and that tells you that the ventilator has not cycled yet and the patient has finished the breath, or you're going to see negative flow, meaning that the patient is now exhaling during inspiration. And so that is the feature of late cycle. So you always come and look at the flow. Now, if you're controlling the flow, like in volume control, then you look at the pressure and you will see a peak in the inspiratory pressure. Now, many people get confused, and we're going to talk about that, about this peak over here that may be or not present, and does not necessarily mean that this is a late breath. And we're going to talk about that, a late cycle. And in the next one, you see an early cycle in which you see now the PMOS goes all the way over here and it finishes, we're going to say here, but you could say here, it doesn't really matter. It finishes here, but the breath ended before, so earlier than the PMOS. So this is called an early cycle. And you recognize it in the flow waveform. The flow waveform is very useful for that, because instead of having that nice peak that you should have, the peak, a nice peak in the flow. Sorry, I'm in a very awkward position there. you're missing all that area. So that tells you that the breath, the patient is doing inspiratory effort. This is is moving towards the baseline. And so that means that the patient is still doing inspiratory effort. So I put that there for you to recognize the patterns. So remember, if you see this pause on the flow, or you see a negative flow, that means that this is a late cycle. And if you see this amputation or this presence of effort during during the early expiration, that's an early cycle. Alrighty, I'll come back to that in a second. Alrighty, now that you have seen these, let's get started with the first case. And as we usually do, I'll give you 1 minute to chat, put in what is the tag, what do you think is the load? So if it's elastic or resistive, or you see a lot of PMOS during inspiration or expiration. And what is the type of patient ventilator discordance? And we go in order: trigger, inspiration, cycle, and expiration. So go ahead and start jotting down what you think is going on while I set up my new. Again, for those respiratory therapists on the line, you can get CRCE credits. So just put your name on the chat, and that will prove that you were here, and then we will give you CRCEs. Excellent. So I see Chip has put already the tag. Keep going. I'll give 1 more minute. Excellent. So I see, all right. People are starting to pour in their answers. That's great. This is very good. You're starting to, this is how you prove your concepts. Just put it as much as you want. Excellent. So the targeting, the tag for this mode, it says pressure support CPAP, and then these little 2 arrows to pressure control, and that's the backup mode, but that only gets activated when the apnea alarm gets activated. So this is indeed pressure control, as all of you recognize, CSB, and it's S. So meaning all the breaths are spontaneous. That means that they are triggered by the patient and cycled by the patient. And they're set points, meaning that you set up the amount of pressure support that the patient is getting, and that is what is going to get. So, excellent. In terms of the load, all of you have recognized that there is a lot of PMOS. And when there's PMOS, it's very hard to see the reality of what's happening in the universe, meaning it hides what it is. But because we're in pressure control, we look for the load on the flow waveform. And in this one, as you recognize, there is not a nice decay. This should decay exponentially, and it doesn't. And so all this area over here that I'm shading is the presence of PMOS. So I cannot see if there's elastic or resistive load. And then during expiration, I see the flow being deformed, and actually there's this odd waveform over here. And then this one does decay exponentially, and it seems to decay in 1.5 seconds, but still not reaching baseline. So I would say that there is PMOS with plus minus resistance. I'm going to suspect it, but I would like to see more. I cannot confirm it, so I'm going to put some question marks there. In terms of the trigger seems to be right on. I mean, the moment that it crosses the flow, it does drop below the baseline, but it's pressurizing relatively fast. So I would say that this is normal, which is aligned with what I'm seeing on the. Then in terms of inspiration, do we see severe work shifting? No, the pressure is not dropping below the baseline. Are we seeing under assistance? And I would say that it doesn't, I mean, there is assistance. This patient is doing a fair amount of work on its own. So the patient is doing effort, and it's getting support through this, and it's not getting under. So I would say that this is most likely normal, although the patient is doing a fair amount of work, but it's getting, so you see it's getting 800 of tidal volume. per breath with only 8 centimeters of pressure support. So this patient is doing a fair amount of work. In terms of cycle, the team recognized late cycle. So this is good. I see a late cycle, I see an early cycle, and I see a normal cycle. So we have a perfect balance. There's equipoise in the answer. So let's read this waveform together. So we're controlling the pressure. So the area that we're gonna come and see is the flow. Remember, if you control, that's why it's so important to know what the tag for the mode is, because it will tell you where to see. So because we're controlling the pressure, I go see the flow. And as I see the flow, I see that it crosses immediately from the top to the bottom. There's no shelf. There's no pause in between inspiration and expiration. And I see that on both breaths. And so that tells me that this is not a late cycle. So I'm going to cross it out. That's out because there's no shelf. Now, some of you may be looking at this little peak over here and saying, whoa, that's a late cycle. But that is actually a artifact that occurs when the breath, the ventilator, well, we're going to get back to that. Actually, it's good. So you would call that a late cycle. But you can see that there's this peak. If you saw that, many people call this a late cycle, but you can see that the flow is crossing straight down. But you can also see that this patient, instead of having that nice decay that you were expecting, has this very high flow all throughout, and then it switches rapid, it relaxes, and it goes to exhalation. Actually, the exhalation looks passive on this case. So this tells you that this patient made a lot of effort to inhale and then relaxed completely. And as the respiratory system relaxes, the chest wall relaxes, the diaphragm relaxes, it comes back. And these ventilators, as many of that are available out there, do not control pressure very well. And so the flow is changing so fast, it's dropping so fast that the ventilator doesn't have time to adjust. And you get to see this beak over here that tells you that this is an early, that would be consistent with a late, but it's not late. You can see that there's no problem on the flow. So this is an artifact. And the same on the other one. As the system is relaxing, you see that beak over here that may make you think that this is late, and this again is a artifact. So that's not late. Now, in terms of being early, you can see the classic feature here of that this is amputated, right? So it's missing that little beak that you see over here. You see the beak here. You don't see it over here. And that tells you that this is moving towards the baseline, which means that this patient was still, for this effort here, was still doing effort. So if I wanted to put the length of PMOS for this patient is around this long. This is how inspiration, the length of inspiration for the patient. So this is, the first breath is early cycle. The second one is a normal. So this is early, and this is a normal cycle. You can see how beautiful it looks. So this is a good contrast of how normal cycle and early cycle look. And then in terms of expiration, I think there's some expiratory work here. The patient is active and then exhales, and you can see the difference on the height of one that is relaxed and the other one where it's doing effort. So this looks like to be an amount of expiratory work. Now, let's look at the comments. Any questions, disagreements, anger management? Ah, I love it. So if the patient cycles, that's the question from Chip, how can it be early? And it all has to do with this value over here, Chip. That's the end inspiratory variable. So the threshold at which it cycles off. So what we're telling the machine is that it's going to cycle off at 30% of the peak inspiratory flow. So it takes this peak inspiratory flow and it gets the 30% of that. But when it's left, it cycles off. So you can see how you can see the angle here. I'm going to make it big so you can see it. You can see that little angle when it turns off, boom. and it goes down. And you can see that happens here, but you cannot see it because the patient was relaxing so rapidly. So that's how it can be it can be early cycle. Now I'm going to show you a slide. This one probably represents it better. This is again pressure support, so it's PC CSB S. And what you have here, it's this patient has that beak that I showed you before, so that many people recognize as a manifestation of late cycle. And you can see again that this is crossing very nicely, right? You can see that it crosses and there's no pause at all. This is a patient with a lot of PMOS. It's expiratory PMOS and inspiratory PMOS. And in this case, the end inspiratory threshold is set at 1%. That's the lowest that we can set it, meaning that from the peak inspiratory flow, the machine is being cycled off when there's 1% left of that. And you can still see the peak there. Then just to prove the point, you can see at an end inspiratory now of 20%. So now it's cycling at 20%. And you still see that so actually if you would see it the other way around, if you start over here at 60% end inspiration, you can see that it's finishing right here, and in this one it ended down here. So the cycle threshold, we have been changing it, and you can see that the beak is still there, that artifact that I mentioned about. It doesn't go away. So this is just an artifact. It's just to prove that this is an artifact. But now you can see, because I have gone down on the end inspiratory threshold to 60%. So now it's finishing up here, and you can see the evidence of the early cycle chip. So now you can see that. You see how it was no early cycle, no early cycle, and now here there's early cycle because we're cycling very early. Hope that makes sense. Yep. Excellent. I actually heard you say that in my mind, Chip. Alrighty. So now let's see the next one, right? So now you have, again, this is a similar example, but this is to drive a little bit home. So it's the same tag. So PC CSB S. So again, all the breaths are triggered by the ventilator, and they're cycled by the patient. And again, the cycle threshold has not been changed on this patient. But I thought that this would be a good example. Again, there's PMOS, as we referred before, and there's PMOS during exhalation, but the trigger continues to be normal. There continues to be work shifting, but it's not severe. And we now look at the cycle, and this one I placed it here so that you can see 3 items. First, there continues to be that beak up here. You can continue to see that. So remember, you're controlling flow, so you don't look at the pressure. You look at your flow. And you can see again that the breath cycled, but the patient continued to do effort. And you can see that it was about to trigger another breath. And it could have if it had crossed the baseline, but it was about to, it didn't, and then it relaxed and exhaled. In the next breath, the same thing. It ended here. And in the next one, but I didn't get it, and I almost cried, is you see that it triggered actually the next breath. So you see, trigger one breath, the flow goes out, and then it comes up, and you can see here the color marker. I'm going to make it big for those that are using the phone. You see the white marker that it triggered another breath. Sorry. So it triggered another breath, and so it essentially double triggered. So for some people, think that pressure support would prevent you from having double trigger, but this is a clear manifestation. This is a double trigger in a patient with pressure support due to early cycle. Now, many people this is a common question that I get is why would that happen? And we have to remember in a sense that the activation of the diaphragm is not a beautiful semicircular shape. Sometimes it can activate like this, sometimes it can go and cycle off like that, meaning that it has different shapes, different uh, forms that you may have. And this patient is having a large activation of the breath that, I mean, the flow goes down and eventually the patient continues to do effort. So this is the right mode for the patient, but probably the variable that we need to adjust is the expiratory threshold and try to prolong it so that the patient can exhale appropriately. Questions, comments? Mm. So the Ariel Garnero puts here, well, maybe you could use an adjustments, automatic adjustment, and there's some software out there uh, in some ventilators that can adjust the expiratory threshold uh, for patients on pressure support. So I believe it's called IntelliSync, of all things. I have not had much experience with it, but that would be the promise of one of these items. So again, this is early cycle. I mean, just driving it home to all of you. And you can see actually another way to see it. I always like to see at the pressure waveform after I make the diagnosis down here to see how it looks. And you can see how the pressure drops as the patient is doing the effort in. So the patient is inhaling and then the patient goes into exhalation, it relaxes. And because the ventilator is a poor controlling of pressure, it has this increase in pressure above PEEP or above baseline. Very good. And just to finalize, this is exact same patient, but it has the same features. But I thought that it would be good for us to review again the activation. So CSBS, and what you see is it's triggering, right? Each one of the breaths is patient triggered very nicely, very nicely, very nicely, very nicely. And then look at the activation of the diaphragm on each one of these patients. So it activates. This one finishes relatively nice. It has a peak. The next one is more rounded. So there was a little bit of early trigger. And the next one, it was less. There's still a peak. So you may say, Eduardo, that's okay. And the other one, it's actually pretty normal. However, if you see the flow, look at the activation of the diaphragm. In this one, how much flow? In this one, it kind of triggers and then it kind of hiccups within the same breath. So inside. In the next one, it's a really big and sharp breath, and then it decelerates and goes out. So the point being that in some of these patients, they're going to have every single type of activation of their size of their waveform. So you want a mode that cycles following as best as it can. And I would argue that in this one, I would not change anything. I would relax and let it be. Even though you're seeing these peak pressures, again, that are related, these are all artifacts that are occurring. The other thing that we thought that was interesting to watch is how you can see on this one a little bit better how there's activation of the expiratory muscles. So you can see here how it exhaled and then there's essentially no flow. This one, there's still kind of an attempt, relaxation, inhalation. On this one, there's this shelf of the patient exhaling, using accessory muscles to exhale, and then relaxes, there goes to baseline, and then inhales. So a lot of PMOS everywhere during inspiration and then actively during exhalation in and out. So if the question was, what mode would I use on this patient? I think that given all the variances, I would ask, now that you have seen this amount of cycle issues, besides pressure support, which is a good option for this patient, is there other modes that you would use? Anybody? You can type it on your thing if you have. So the question, Chip, is is there any other mode that you would use for a patient with all these problems with cycle and activation of PMOS? So there's a couple of comments. I'm waiting to see if there's more. There's one from Mike Smith talking about NAVA. NAVA is a potential for a patient like this, is to see if that would help give proportional support to the amount of work that the patient, and because it's using the neural signal, it would trigger and cycle in sync with what the patient is doing. So that may be an alternative. If anything, it would be in somebody with so much activation of the PMOS, you're wondering if the patient is getting what it needs. And so it could be NAVA or PAB as two potentials. Ariel mentions, well, there could be, there's always going to be more or less conflicts with the neural and the mechanical TI. And that's true. There's even though NAVA or PAB or pressure support are supposed to be the best at synchrony, there's always going to be some degree of desynchrony. And so the message here may be, well, there's some things that you may not be able to cure, or that you don't need to cure. This cycle desynchrony may be too little to be an issue. But we don't know. There is no data right now that tells us that cycle desynchrony is safe on our patients. I see also a comment from Chip saying, well, he's 8/8, 35%, extubate this patient. And that's a perfect segue for the statement of, does this patient need or not a mechanical ventilator? And so extubation may be the next step on this patient, and sometimes you cannot do anything with them with the ventilator. So I'm going to put there for a little bit the CMEs for the CCF caregivers with the code. Just copy that code so that you get to put it in. And then there's the CRCs for the RTs. Please fill the evaluation. This will help you get your CRCE points, units, values, whatever it is. And we would love to have you next week. We're off, but in two weeks we're going to have another case. This is a fresh case that we also had that has a lot of clinical implications. Again, if you have any waveforms that you want us to go over, please send us to Twitter. That's my handle. There's also the emails for Rob and myself. And there's the VentRounds page, which is getting updated. Please, the more we interact, the more we learn. Thank you very much for your time. Again, have a good one. And Ryan has put on the chat the forms for the evaluation. Just click it if you're a RT, and you'll get it done. And that's it. Thank you all.